Welcome to the Voices of Otolaryngology podcast series, where we spotlight diverse perspectives and insights within the field of otolaryngology. I'm your host, Rahul Shah. Let's jump into it. Welcome to Voices of Otolaryngology. We are closing up the expo floor. It's Monday, October 13th in Indianapolis, and I'm meeting a new friend, Greg Basura.
That's right.
Greg or Gregory?
Greg. Gregory, if I'm in trouble.
All right.
Greg, I hope I'm not in trouble.
No, we just have gratitude for you today, really helping with our international work. It's pretty awesome. Tell us a little bit about yourself.
So I'm currently a professor of otology and neurotology at the University of Pittsburgh. I just moved there a year ago. I was on faculty at the University of Michigan for 12 years and made a jump.
And how about before that?
So before that, I did fellowship at Michigan, and then I did my residency at Carolina Cadet School in Seattle.
Cool.
So I'm MD PhD, and currently in the division of otology and neurotology, and I share my time. I basically have three full-time hats. Clinical, I have an NIH-funded lab. I'm an R01 grant. And then I have, I'm the current lead for global outreach in the department.
Wow. And you wear an academy hat.
I wear an academy hat. I'm currently the Humanitarian Efforts Committee chair for one more year. I've had that phenomenal post for the last 3 years, and I've got one more year, and our chair-elect Ryan Belcher from Vanderbilt will take over the reins next fall in Los Angeles.
Sure. So we have a wellness zone back here. You might be someone who needs that. You're doing so much work. I got to get you some massages.
I do. I was hoping that could, maybe some of my academy dues you go towards that.
It sure does. It sure does. We take care of our people, most definitely. So what was your PhD in?
Anatomy and cell biology, but it was all neuroscience. My thesis was in Parkinson's disease.
Oh, wow.
Looking at alternative neurotransmitters to substitute dopamine to re-regulate a basal ganglia that gets dysfunction.
And that was at Seattle.
That was actually at Wayne State School of Medicine, Detroit.
It's terrific. Yeah, very cool. And you're not too far from that, otology, neurotology. What's your R01 funding?
So the R01 funding is to basically two things. One is to objectify human tinnitus using innovative brain imaging, using functional near-infrared spectroscopy. Basically, that's...
Whoa, go back. Hold on. I got the word objective.
Yeah.
It's very important. Hold on. I think I got to say it one more time. To objectify human tinnitus in the human brain. So we know that tinnitus, or phantom sound in the absence of a sound stimulus, is a brain phenomenon. The brain is doing that. And so you want to image that.
And I'm trying to objectify a subjective problem using a non-invasive brain imaging technique called FNIRS, or functional near infrared spectroscopy, which is basically pulse oximetry for the brain. We use hemoglobin concentration as a surrogate of neural.
So you put something here?
Yep, EEG style optos that pass infrared light into the brain. And then I can measure hemoglobin concentration under different conditions of stimulation.
That's incredible. What are you starting to see?
So we're starting to see phenomenal things. So I was a basic scientist before that. We used to see two neural correlates of tinnitus in the animal models. One is increased spontaneous firing of the auditory pathway on its own. This increased spontaneous firing we found, it's called central gain, usually in response to hearing loss.
Of course.
That byproduct is what we think people hear. But then the second neural correlate is neural synchrony. So misery loves company. Neurons are not only firing spontaneously, they're firing together.
Wow.
So in the human brain, we never had a correlator. So my hypothesis was that's happening in the human brain. And lo and behold, in the auditory cortex, I can measure in someone who has tinnitus that their cortical function in silence is at a higher basal rate than somebody who doesn't have tinnitus. And so we're measuring that, and we're doing some different things with what's called somatosensory tinnitus, which is a different bird, but it's people that have bad jaws or teeth, neck whiplash injury. They can have tinnitus without hearing loss, and it's because the somatosensory circuits feed into the brainstem auditory circuit. So they can modulate their tinnitus by moving their head and neck. Tinnitus goes up or down. So we're objectifying out as well. So the goal here is to find the key parts of the brain that are aberrant, and then target that with some retroactive animal studies and looking at neurophysiology, neuropharmacology, and even some retraining devices to retrain with circuit.
I got it, man. Give me 5. I understand it. What a great description. That is super incredible. Super incredible.
It's real exciting, and obviously clinically applicable.
So Dr. Basura, that's amazing. And I always love learning about our guests, and congratulations. You are on the young side to be a full professor, and you've been grant funded. That's phenomenal. Congrats on that.
Thank you.
your passion, one of them is humanitarian work.
Absolutely.
You've done an incredible amount of work.
Yeah.
How? Why? Tell me some stories.
Well, my first experience was with Brent Sr. Brent Sr. is a rhinologist. He'd been going to Vietnam for 15, 20 years. And my first experience in global medicine was with him going to Vietnam for Hanoi.
As a resident,
As a chief resident at UNC.
so 2005.
This was 2009. I graduated in 10, so my fall of 9 going into my last year. And what I learned from that experience was from him is he'd been going there.
So you graduated residency your year?
2010.
And you became a full professor when?
Just last year.
It's like one of the fastest pathways, man.
Oh, it was great.
It's a nice time to tenure.
I love it.
At two amazing institutions, Michigan and Pitt. Wow.
Thank you.
Congrats. That's incredible.
What I appreciated with Brent's work was the connections he made with international partners and how they could learn from each other and the contributions he could make and the things that he could show them to expand their skill set and how they could manage patients.
So you started in Vietnam,
and then right there, then I went to fellowship, and I knew right away, I'm going to build this. This is going to be part of my career. And so when I graduated, fellowship, started faculty in August of 12
at Michigan.
I jumped right into humanitarian work.
What do you mean jumped in? People always say, how do I get involved at the academy? So how did you jump in?
So first thing I did was there was a private Kenya Relief, which is an organization that was going to Kenya. It's really not affiliated with an academic organization. So I thought, okay, I'm going to go with them and see what that's all about. So we went to Western Kenya, small.
How did you find this group?
Oh, one of their main advocates was a nurse at Michigan.
Oh, fine. So your network.
It was right there.
So you had the bug and
and I found it right there.
So you weren't looking for head and neck. You weren't looking for otology. You said, I'm going to do medical mission.
I'm going to do a medical mission.
All right. So you went to Kenya.
I went to Kenya. We went out to this small clinic out in the middle of Western Kenya, Migori, near Lake Victoria. And that was more of what we call a mission trip, where we dropped in, we did cases. So we weren't really training people. And then we leave. And I really reflected on our experience. And I thought, okay, that's phenomenal. We're servicing and we're helping a needed community. But I thought to myself, I want a true partnership. I want what Brent Sr. was.
We all want what Brent Sr. has. Do you want to grow up to be Brent Sr.?
Well, yeah.
I do.
Yeah, sure.
We love that guy.
Yeah, absolutely. So the idea was, okay, that's wonderful what they're doing, but that's not exactly what I'm looking at.
Okay, sure.
So it turns out University of Michigan, obstetrics and gynecology have been going to this place called Cath Hospital.
Buddy, you're an otolaryngologist. You're hanging out with OBs?
Well.
All right, so Vietnam, then Kenya. But now you found OB.
Ghana. No. I found Ghana.
Okay.
In Kumasi. The obstetrics department in Michigan have been going to this hospital in Kenya or in Ghana for 30 years.
How did you find that out? Just talking
found out through my chairman at one of my faculty at Michigan.
So you start again using your network.
That's right, using the network, absolutely. So went over there as a basically a needs assessment, and they had a residency there at Cath Hospital. So 2 attendings, training residents in an otolaryngology department.
Oh, cool.
What they needed most was ear surgery. So I'm a neurotologist, I'm an otologist, and like perfect. So we go over there, we build them a temporal bone lab. I give their first temporal bone course.
Buddy, you mean built them a temporal? You thought about it here, what you needed, and you came there and set it up.
So we got some small funding from the department and matching funds from the
foot pedal, drill,
microscope, drill, the instruments they need.
Yeah.
We went in there, built a 2-station temporal bone lab.
Amazing.
Yeah, we took a microscope into the OR for them. So our first week over there was, okay, let's do some temporal bone teaching. Let's teach in the clinic on good ear exams, and then we'll do some basic cases. So that lasted for 3 years.
You say mastoid basic cases?
Yeah. And so that evolved over 3 years, where we were going twice a year. And I realized after our 3rd year that we weren't making the traction or the
impact that you wanted.
Correct. And there were many reasons that probably go beyond our time here. But what I realized was I'm the fellowship trained neurotologist. After 5 years of residency, I did 2 years of fellowship. I would argue that folks in the developing world, they need as much training as possible because a lot of their residency training is
it's very cursory.
So I realized this after it not taking hold in that model. So we learned that model was not ideal to get them where they needed to be. And we got to build fellowships. So I started thinking, okay, there's only so many places in Africa where they have the infrastructure and the capable instructors to do this. So I looked north. I looked into Egypt. I went to the University of Alexandria and I pitched the idea of a fellowship, and they loved it. I wrote up the whole proposal. I gave it to the university. Done. They got 2 professors there that are otology trained. I identified the first fellow from northern Ghana. I had partners that were going to come in. I was going to be going out. It was great. And then pandemic, blew the whole thing up. So as we emerged from the pandemic, most of the key players had moved away. And so it actually had been dismantled. So I called my old friend Johan Fagan, University of Cape Town, South Africa.
Celebrated as a living legend.
That's right.
Did you get to see that at the opening ceremony?
Absolutely. And let me just diverge in a minute and say no one deserves that more than Dr. Fagan. Incredible. Just amazing.
We agree.
20 years of head and neck fellowship. So he had built the fellowship modeling app. And so I called him out and said, Johan, you need to build an otology fellowship. And he's like, well, Greg, we're about to launch it. And I said, are you kidding? And he said, yeah, we're in communications with MED-EL. They're going to fund it. Tashanine Harris she's the otology fellowship trained faculty on the Brown. And they said, Johan, I want to be involved. I was like, absolutely. So Tashim and I teamed up, and our first fellow started in March of 2022.
And the fellowship is based where?
In Cape Town, South Africa, at the University of Cape Town. And it's a 1-year fellowship. And
who's it open to?
So it's open to only Africans.
Yeah.
It has to be an African physician with a gentleman or gentlewoman's agreement that they're going to go back to their home country.
Sure.
So it's a 1-year dedicated fellowship. MED-EL pays the stipend. They give 10 Otolarian clients free implants for their fellowship. Tashanine trains them on a week-to-week basis every Friday for the last nearly 3 years now, almost be 4 years in March next year. I do a Zoom lecture every Friday morning at 5:30, 6:30 in the morning. So we're on Zoom every Friday doing lectures.
And you kind of have a curriculum.
Absolutely.
Who's attending that lecture?
So the fellow, the Cape Town residents, and Brad Welling from Harvard has joined me. And it's just a small group of us.
How many residents do they have?
Well, they're spread out. So on the otology service, there may be 1 or 2.
You're absolutely amazing. Every Friday, you're out at 5 in the morning, 5:30.
We do a Zoom
to give a lecture to 2 people.
Absolutely. Every Friday.
That's amazing.
Every Friday.
You know what pisses me off? Some people are like, oh, I want the auditorium filled. I want 100 people. You're doing this for 2 people that impact thousands of lives.
Absolutely. And what they do is it's bidirectional.
Of course. They have their questions.
Absolutely. And so
Dr. Basura, I did this last week.
Or Amina, the current fellow, she's like, Greg, we have an interesting case. Can we move in on, and then we'll go back and forth.
What a treat.
But then I have audiologists giving lectures, vestibular lectures. And then the otology residents on the service, they're required, as I've started at Pittsburgh, the otology residents on the service have to give a lecture. And then the fellowship for our fellow, they have to give 2 lectures per year. So have you ever
thought about this? The irony of what you wanted to do in Alexandria, Egypt, got interrupted by the pandemic. Yes. But the pandemic has now facilitated global learning. Is that ironic?
The cool thing about this is now we have a sustainable, tried and true model for fellowship training in the low and mid-income countries. And the cool thing now is Amino Seguya, the current fellow from Uganda. So our first fellow from Zimbabwe, second from Ghana, third from Kenya, current from Uganda. She's going back in her home country, and her home institution just gave her the green light to be the second fellowship on the POC. To be the second fellowship center for otology on the POC.
Whoa. She's going back to where?
Back to Uganda.
How did they give the green light? Competence and value?
Absolutely. And plus, one of Johan Fagan's old fellows is there, and he started a fellowship, and he already had gone through the process through the academic. So they need an institution. So now the otology fellowship is following suit. So now you'll have fellowship trained otologists there starting a fellowship.
In Africa, then, they must have the analog of our ACGME. Is that what you're getting at? Somebody has to stamp.
That's exactly. So, great question. So now we take it one step further. So I knew that fellowships would be popping up. So as almost 2 years ago, November of 23, I bought a domain. I started up the African Otological Society, a once-a-month virtual society, just started from scratch. We just had our 20th meeting 2 weeks ago with the idea of...
And how many folks attended?
There's about 50 on the call.
Oh my gosh.
And there's over 200 that are registered by our site. Wow. And the goal of that is to, one, create capacity and community on the climate, so we know who's doing what. So each month, a new country presents their otology and audiology capacity.
But you also understand what's going on. Absolutely. At a macro level. Absolutely.
But what I also wanted it to become is some kind of umbrella society to start legitimizing fellowships. So that's where it's going. So now the charge I have on me is to push it to the next level and be some kind of standardizing body, which I'm working on that now, because the dangers of people doing training in some place and saying, oh, I did a fellowship. You have to be careful. We want to make sure that the training is legitimate and standard.
So
we're meeting, metrics.
Like the name escaped me, and I want to acknowledge our colleague. Who is the lead otologist in Cape Town?
Tashneen Harris.
Dr. Harris.
Dr. Harris.
Dr. Harris. Well, kudos to Dr. Harris for taking that plunge.
Incredible.
Yeah,
amazing.
Right?
She's amazing.
This podcast is called Voices of Otolaryngology, maybe Global Voices or Voices of Global Otolaryngology. We should edit it.
Yeah.
Talk to me about the incidence and prevalence of ear disease on the African continent. How does it differ? There's regional differences. We know that across the world, but just a little bit, just to educate our mostly domestic listeners.
Certainly. So it's far and wide. So the big issue when we talk about chronic otitis media, usually it's either infectious or it's often caused by an underlying cholesteatoma, which is a fancy word for skin in the wrong place. And
we're still seeing that.
Absolutely. So you see a lot of chronic ear disease in those forms where either in some parts of Africa, particularly in Ghana where I was more congenital. There's some congenital, but there's also acquired. Mostly in adults, it's acquired ear disease where they'll get infection. You still see TB. So the other issue is in Africa, we're in the States and the developed world.
How does that manifest?
So TB in the ear, they can have tuberculosis in the ear. So you can have draining ears, still basically infected by TB.
So what is the surgical algorithm for that? I don't know.
Yeah, it's usually not so much surgical. So treat topically or with other types of agents.
But you have to recognize it.
Absolutely. So ear disease is prevalent. So there's different genetic forms of disease. There's congenital disease. But a lot of adults deal with the sequelae from pediatric disease and never got. So they have perforated drum, subtotal drum, perforation.
You're going to get an acquired cholesteatoma in growth.
Absolutely. So a lot of this is acquired. And the pathology...
And they just live with it.
They do. So in part, some of the things that it's ironic to say this, but many of them have a subtotal perforation. But that's actually good because it's exteriorized.
Exactly.
So they don't actually trap
skin.
And so because I've seen devastating cases where patients have succumbed to meningitis or crane abscess. So there's a whole spectrum of disease, which is why we call it chronic otitis media. But the issue now is the implant companies funding the fellowship with the goals of being eventually implant surgeons. But what we're using the implant companies for is to train or become chronic ear surgeons. So it's a wonderful way for private industry to partner in the educational opportunity, but we're actually
Dr. Basura, what's amazing is implant technology is evolving so quickly.
It is.
There's wireless, there's phones. How you and I did implants and the maintenance of that is going to be very different 10 years from now.
Absolutely.
They can probably control one from California.
Yeah, absolutely it is. So it's really exciting to see where this is going, and I think that I'm so excited to see. So what's amazing about being here at the Academy and being involved with humanitarian efforts and visiting scholars.
So hold on, that's a pin. What is that pin?
Yeah. So this pin is...
You want to show it to the camera?
This pin right here represents the Eugene Myers Global Education Fund.
I just saw Dr. Myers walk in the hallway.
Yeah, absolutely.
He's 91 years old.
And he still travels.
Almost twice the age.
He still travels the world solo. I can't say enough about what he's done, but this pin represents a fund that was named after him based on his legacy of global outreach, so that our international partners in low and middle income countries have the capacity to come to Academy and obtain.
And you see some of your colleagues from Africa?
Absolutely.
That got the Gene Myers.
Absolutely. They're here now.
Is that like a circle?
Absolutely. And they're actually on the African Otological Society calls. So it's really amazing.
Awesome to connect with them.
This week, I've actually met some of my colleagues face-to-face for the first time that I've only seen on the screen.
Did you meet one of your fellows here?
One of the fellows, future fellow. Our next fellow.
Dude, is that awesome?
Our next
fellow. High-five to that.
Our next fellow.
You actually met him here in Indianapolis?
Yeah, she's here. So she's here. She'll be starting in January.
She's attending all the lectures, and she goes home, and she's ready.
That's right.
So do you go back and operate now or take your residents there? I don't think so, because your program's evolved, where you might go back to help from a programmatic administrative view.
Yeah. So for Cape Town, I go twice a year, but I train the fellow in the temporal bone lab with advanced skull base. So I teach them.
Oh, so you more fun.
I teach them how to do advanced neurologic things because you're going to do tumor, but they may have to do advanced cholesteatoma.
Yeah, and you can look at some cases while you're there and help them think about it.
Absolutely. But the neat thing now is my chair, Jose Zavallos, this is Peruvian. So I just got back from Lima. So we are going to build the same platform we just have at Cape Town in Lima. So that's the next plan for us, is to take the same blueprint, hybrid, virtual, all these different things. We have what's called the Brothers Foundation in Pittsburgh. They help distribute instruments and basically take that blueprint now, which is battle tested in Cape Town, and apply it to our next location so we can create long-term partnership, increase their capacity, and then they can enhance their training and their ultimately their patient care.
As we start wrapping up, let's get to the why. Not why you do it, but tell our audience, why should they get involved? And how? It's always intimidating. Started from one guy who listened to an OR nurse who went to Kenya who said, all right. And then you talk to the OBs, you ended up in Ghana. I mean,
it's a journey. I think it's a journey. I think for me, there's always been an overwhelming desire to contribute at a higher level. And I think what's so amazing about our field and in otolaryngology is I think it attracts people that want to contribute. I think it's a wonderful, as you mentioned, we have such an amazing specialty because I think it attracts people that want to give. And I think that desire is already there. So what you need to do is how do you put it in action? And so I think this is where things like Humanitarian Efforts Committee is so important, where we have our tribal grant. So these are the trainees. And what we do is we fund them an opportunity to go and have an experience. So we give them many times it's their first experience.
And who are we funding with that?
We're funding usually residents.
U.S. residents?
U.S. residents.
Oh, I see, to give them exposure.
Absolutely.
I see, to get the Basura bug. Does anyone call it that?
I love
Basura bug?
Well, my last name means garbage in Spanish.
Lo siento, but you're not Spanish, are you Spanish?
I'm not.
Okay, that'd be tough. So the Basura bug.
That's right, yeah. But so that they can have their Brent Senior moment.
Yeah.
And
awesome. How many grants did y'all give out?
So we had, we had 8. I think this
that's super cool. And not all of them are going to convert over, but you're giving them exposure.
That's right, absolutely. So the hope is, I think when you ask how, I think it's like we provide an opportunity. So we take that inherent curiosity to contribute and channel it and say, well, here's an opportunity, and then see where it takes us. And I think that's what we do. I think if we continue to provide opportunities, we're going to have more and more people engaged, building these lifelong journeys, these lifelong partnerships that the dividends are immeasurable.
I cannot wait to repeat this with you in about 9 months or a year, see where you are.
I'd love to.
The progress you're making, you're starting to scale it.
Yes.
You're starting to go to another continent. Mm-hmm. That's insane. And I want to keep up on your R01 work, because that's actually pretty exciting. And I love how you're tackling the big problems of moving, and you're looking at the brain at a different level with the functional IR.
Absolutely.
Pleasure to meet you. Congratulations on all your work.
Thank you.
I've made a new friend. Thank you.
I love it. Appreciate it.
Thank you.
We hope today's episode sparked some fresh ideas. If it resonated with you, please subscribe and share it with friends. Have thoughts or suggestions? Use the feedback form in the show notes. We'd love to hear from you. And don't forget to follow us on social media for highlights, behind-the-scenes content, and updates. Thanks for listening. See you next time.